I'm going to cover two cases in terms of case management on prostate cancer. One is an easy case, and the second is a hard case. And so I'm going to show you in a shared screen how the person that I've managed, which is stage 2 prostate cancer, how it turned out for that person. And so I'm going to share the screen. So this is a 50 plus year old client who has stage 2 prostate cancer, was diagnosed in December of 2024. 9 months later, after the biopsy showing cancer, he contacted me and wanted to go under case management to use the RGCC system to help him in decreasing the cancer cells and hopefully go into remission uh, level. And so this person uh, underwent a biopsy in November of 2024, which was a core needle biopsy. And it showed that there was a sinus adenocarcinoma in the right posterior medial. And he was also given the Gleason score of 4 plus 3 equals 7, or grade group 3. And then also there's in the right base of the prostate, also a sinus adenocarcinoma grade group 2 with a Gleason score of 3 plus 4 equals 7. And then you can see here there's other areas of the prostate showing Gleason 7. And so with this person who has done a lot of research on his own, he decided to go through all kinds of natural therapy options that he knew of. And so he underwent the Cinever MAF injectable. He had sonophotodynamic therapy. He went to Hope for Cancer for 3 weeks, receiving different types of holistic therapies. He underwent hyperthermia 3 times a week. He also did red light sauna daily, every other day, and then LED light pad daily. So you can see all kinds of natural therapies that he knew of that would help him defeat cancer. He also had B17, propolis, ivermectin, fenbendazole. These two are very popular in people who are doing therapy to help themselves defeat cancer. It's a very popular off-label drug. And also coffee enemas and and a whole list of other supplements. He was also on a whole food diet, doing juicing in the weekends, taking black seed oil, sea moss, kimchi, kefir. And in early 2026, he also underwent NK cell infusion and cytotron treatment. In case you don't know what cytotron treatment is, it is a non-invasive um, therapy that utilizes a proprietary technology called rotational field quantum magnetic resonance. This system delivers precisely controlled, modulated, fast radio frequency and magnetic fields designed to target malignant cells directly. And it is he had to get it from another country, but anyway, he did that as well. And so here's the baseline in August of 2025 when I saw him 9 months after he was biopsied, and it shows the PSA at 4.58. And then I 2 months prior, almost about a month and a week prior, I did the OncoTrail prostate, and it shows the circulating tumor cell baseline count at 2.1, and then the subpopulation of the cancer cells that are epithelial origin, it was 1.6. This subpopulation that are EpCAM positive uh, is essentially the population that carries the majority of the cancer stem cells, and the one that I'm really monitoring is the OKT4 um, CTC that has this stem cell marker on it, and that is the aggressive uh, circulating tumor cell or cancer stem cell that dominates and drives the disease. It's one of the two, which is SOX2 is the other one. And so this small population of circulating tumor cells with the OKT4 makes it uh, resistant for treatment in terms of risk for resistance and also risk for recurrence. But it's not considered a high risk. Would be at this point less risk since it's only one of the cancer stem cells showing the positive, which is in this case diminished positive. So I look at the breakdown of the phenotype markers associated with the circulating tumor cell of 2.1 cells per mil. That would be considered the baseline. So he doesn't have a high tumor load since we I in my own experience I see that 2 cells per mil is the cutoff. If anyone is able to drop below 2 cells per mil, as long as it correlates with imaging, then it is significantly lower risk of future disease progression. So I always aim at reducing CTC to less than 2 cells per mil, or if it's breast cancer, it would be less than 2 cells per 7.5 mils. So he didn't have a high tumor load to begin with, but at any rate, it is a Gleason 7, and with a slightly elevated PSA of 4.58. And so in this particular case, this person doesn't have a high aggressive risk, but there is a certain amount of risk though because of this cancer stem cell OKT-4. So you can see here that for PSA, there's a diminished positive detection in the circulating tumor cells for PSA, but for the PSMA, which is the prostate specific cancer stem cell antigen, 75% of all the circulating tumor cells or CTCs are positive. So, so what we want to see here is that they remain the same all across the therapy uh, care, and if it remains the same or go higher, that's what I look for, and not to see it decreasing or downgrading, which is generally not a good sign. And as far as the behavior of the cancer cells, looking at the tumor stem cell marker OKT4, you can see that throughout the entire time, this behavior has not downgraded to negative, which is what I would like to see. However, since the CTC number decreased to less than 2, that's satisfactory as long as it also correlates with imaging. And you can see that even though there's a slight increase in the PSA, the prostate-specific antigen that we're looking here is a serum test, and this antigen is found in the serum, whereas the PSA that you're seeing here on the CTC line 37, it's diminished positive, and that is on the surface of the circulating tumor cell. So it's a different PSA test. One is in the blood in circulation, where the other is on the surface of the CTC that is circulating in the blood. So detecting it directly on the CTC is better because we are looking at the live cell instead of uh, antigen that has been released by live cells along with dead cells that are in the serum or in the blood. So, so for this patient, for this client, he did remarkably well. He did not receive any conventional treatment other than that biopsy that he had in 2024. So he wanted to pursue just all natural approach, which he certainly, you know, can decide for himself, and he understands the risks, and so it's not anything that he does not know about. He did his research and he chose to go this route, and so I simply ordered a test for him and created a specific plan of therapy. And even though it is a slow process of decreasing CTC, he did accomplish reducing his CTC down to 1.8 as of March of this year. So from June of last year at 2.1 to go down by 0.3 to less than 2, it's 1.8 in this case, and it took that long from June to March to drop from 2.1 to 1.8. That's a very slow process. However, it is consistent at this point with a very low disease load. His subpopulation EpCAM cells started at 1.6 and now it's down to 1.4. And usually people who are in the remission territory is somewhere between 1.4 or less cells per mil in the EpCAM positive CTC population. So that's already in the range of remission territory. So his case was an easy case, and you can see that he has a genetic profile here. So the OncoTrail shows the phenotype marker, which is the behavior of the cancer cells primarily that I'm monitoring, along with associated source, which is the PSMA and PSA. That means that it is a prostate origin. But I'm looking at the behavior, which is the cancer stem cells right here. OKT4, the CD133 is also a cancer stem cell marker, and also the NANOG, but they are of lesser hierarchy compared to the OKT4. And so the genetic profile, if it's marked red, that means it is overexpressed and supporting the cancer's cells proliferation and increasing activity. So you can see the MDR1 MRP, these are resistance factors, and that's considered a high resistance factor, resistance to treatment. And so that means that it can develop secondary resistance easily. And so we have to address that. And these are the growth factor receptors that are overexpressed. Interestingly, for this gentleman, his IGF receptor 1 and 2 are normal. So carbohydrates and insulin are not really a main factor in terms of supporting the cancer growth. So he's fortunate in that case. In his situation, one of the main drivers are the angiogenesis genes right here, which is highly expressed. So the blood supply and anything that is blood formation is the cancer's advantage for growth, and so that's one of the things that we have to keep in mind, that if it's highly expressed for angiogenesis, we want to functionally uh, reduce or down-regulate that pathway to not support the cancer. Okay, so here we can see what agents are considered high efficacy. If it's over, if it's 10% or higher, I would consider that. And in this case, we had a few that showed sensitive, like ascorbic acid, vitamin C is one, the artisan or sweet wormwood is another, super artemisinin. So these are considered agents that can be selected for him since it's the highest expression, highest sensitivity among the agents tested. So we use them in his protocol. So that's an example of a good response, even though it took a long time to accomplish, to reduce to less than 2. It took essentially from June to March. That we're looking about 9 months, and now he's down to 1.8. So which is reasonable, and he was very happy, and I'm very pleased for him to accomplish this without any conventional approach. The next one I'm going to share with you is going to be a harder case. So I'm going to stop the screen share for a minute and open up the other spreadsheet. Now this one is a much harder case, but it still was successful. It is stage 4 prostate with a Gleason 7 to 8 with metastasis to the bone. And so this is really advanced disease. It went to the ribs, pelvic bone, and lumbar area. And so when I saw him in November of 2023, he was diagnosed a month prior with a biopsy. So he was essentially biopsied, proven cancer, and then he contacted my office, and I was able to get him tested. So you can see that his baseline PSA was 36.93, and this was 2 weeks before I saw him. He did the PSA test, and then we did the baseline RGCC testing with the Oncotrace and Onconomics Plus in December. So essentially 1 month after his initial consult, we ran the CTC and it was 4.8. And that is 4.8 cells per mil. Now, when I looked at his phenotype markers, you can see that both OKT4 and SOX2 showed positive. And so that's a high risk for resistance and reoccurrence. That the behavior is aggressive. Fortunately, it was not highly metastatic, even though at least at the present time, that was when the test was done, although it had already metastasized previously to the bones. So as far as the activity in terms of metastasis, at the time the test was done, it was not highly metastatic in that population of CTC. It was just highly aggressive. And then the subpopulation, EpCAM plus VE was 3.9. So the goal, of course, is to decrease the CTC to less than 2, and the EpCAM plus VE to decrease that to 1.4 or less. And so he began his therapy, but he was also being treated by oncology. And so he was on docetaxel, and then he underwent radiotherapy, did a hormone blockade with Zytiga, Eligard, and then a bone protection with the Xgeva medication, and he also did the proton radiotherapy. And all this was done in 2024, and during the time that I was also working with him integratively. And so he was very determined to defeat the cancer because it's a very advanced disease. And you can see here that over time, his CTC went down. So even though he was undergoing chemo treatments, the number went from 4.8 down to 4.2. A few months. This was basically 5 months. 5 months after the PSA at 36.93. 5 months later, and actually December to so 4 months after the baseline 4.8, it was already down to 4.2. So that was a very good change. I'd like to see that ideally a drop of 0.1 per month. Now from this point onwards, from 4.2, and I saw him in October, and that is about six months. It's already down to 3.3, and the population of the cancer stem cells also downgraded from positive 25%, and it dropped down to diminished positive. So that's a very good change when it's downgraded. And even though it's still considered high aggressive risk, the downgrading of the SOX2 is very favorable, which is not as aggressive as if it was higher. So this is a good change. And then the subpopulation also reduced in proportion, and finally is reached at 2.5 in January this year, and his EpCam plus VE is down to 1.9. So looking at this two, from where they started, and it took 2 years and 2 months to drop down to the 2.5 CTC and 1.9. It's not done yet because the goal is to get it down to less than 2 on the CTC, and the EpCam plus V to go down to about 1.4 or less. So it's going to take some time, but it's getting closer. And this was also favorable from the genetic view because he turned off several of his cancer genes that are overexpressed, those that are in red. So you can see there's a lot less of the red highlights on the genes. So it basically translates to anything that's reducing expression towards zero means that he's going in the right direction, turning off the cancer genes. So that's what you're seeing here is many genes have downgraded or normalized, which means that the cancer genes have turned off. And the likelihood for this person to develop a recurrence is going to be a lot slimmer because the cancer genes are turned off, and many of them are turning off, and then at the same time the CTC is coming down. And as far as the person, as far as imaging goes, he's also looking really good. No more activity detected, and his PSA is already has been less than detected less than 0.05, and very stable. So all those are correlating with significant improvement, and essentially no evidence of disease activity, even though his CTC is still detectable. But that's fine because eventually we'll get that below 2, and that ideally would be a signal that he's ready for maintenance protocol, and we'll just follow up with him once a year after that. So that is the presentation tonight on prostate cancer and management by RGCC. testing and personalized therapy based on the RGCC's Economics Plus test.